Dr. Wenlong Su. Dr. Su is graduated from Kaohsiung Medical University, Taiwan in 2007, and he completed his residence and achieved resident training in Department of Surgery, Kaohsiung Medical University Hospital. And now he is the visiting staff since 2012 in the Department of Surgery, Kaohsiung University Hospital. He is master in hepatobiliary surgery and digestive surgery. Today, he will give us a talk about the standardization of single incision laparoscopic cholecystectomy with large pore. Dr. Please.
Thanks, Professor Zhang for the introduction. Ladies and gentlemen, thanks for the Chief Peng to invite me for this presentation. My topic is standardization of single incision laparoscopic cholecystectomy with large pore. I'm Dr. Su from Kaohsiung Municipal Datong Hospital. As we know, laparoscopic cholecystectomy has been the standard procedure for the gallstone disease, and it progresses from the multi-port to nowadays the single port. So we searched the English literature for the meta-analysis to compare the single incision operation and the conventional laparoscopic operation. Now this meta-analysis show that the single incision laparoscopic cholecystectomy has an advantage in cosmetic score, short length of incision, and post-operative pain. However, SILC surgery has a longer operation time than the conventional surgery. Now the 2014 meta-analysis also showed that the single incision surgery had reduced postoperative pain, lower rate of analgesic use, better cosmetic scores, shorter length of stay, and shorter incision length. However, it also showed that the SILC surgery has a longer operation time. The British Journal Surgery 2013 showed that the single incision has the greater intraoperative bolus. I think this may be the procedure is more difficult than the conventional laparoscopic surgery. So I will introduce my operation skill to you. This is the large port made in Taiwan as we can. And finally, this is the port. It has four ports. 2 for 12 millimeters, and the other 2 for the 5 millimeters. This is the endograbber. One side is for the gallbladder, and the other side we can use it to grab the gallbladder to the peritoneum. And we can see this instrument in the video. Now I will introduce my video. This is our table. Our patient lies supine position with the reverse transdermal position. And my assistant will stand between the patient's legs, and I will stand on the left side of the patient. This is the large port. And the insufflation is from one end. This is the cameraman, and I stand beside the left side of the patient. You can see the camera is on this side, and my both hand will on the same side of the patient. And we can see I didn't cross my hand between the scope. And I use the elongated grasp hook and the dolphin grasp to facilitate my procedure. Okay, now I make an incision. This incision, you may make a longitudinal incision or a transverse incision. And the fascia will be dissected as the longitudinal position. If the two position is the same, the wound will be in a fusiform pattern. If you make an incision, a transverse skin incision, and the longitudinal fascia incision, the wound will be in a circle. Okay, now I dissect into the peritoneal cavity. this is our wound projector. I didn't make the incision in the bottom of the umbilicus. This makes our further repairs difficult. Okay, this is first the wound projector. And now we cap the cap. Well, this is our port. And we insufflate the carbon dioxide from this side. Okay, we can see that this wound is the circle, and the breast is one finger breast. Okay, we can see this is the endograph. We use one side to grab the gallbladder and the other side to the peritoneal cavity. Then we can do the intracorporeal traction. And now this is the procedure as the conventional laparoscopic cholecystectomy. This is my right hand. My left hand is disappeared on the screen. This is the great precision in my practice. I will show the instrument position later. This is the hemocrypt. All the procedure, I didn't cross my hand between the scope. After the CC duct clipping, I hold back the endograph because this traction will make my dissection of the gallbladder of the liver difficult. Okay, then we keep on dissection of the gallbladder. Now my scope is go to the right side of the screen, and both instrument is on the left side. Then we can remove the specimen from this single incision wound. Initially, we use the SILC surgery in the easy case. Then the difficult gallbladder, after we increase our experience, we try to practice our experience on the difficult gallbladder. The difficult gallbladder will make a bloody environment. We can see that this is our left hand, this is our right hand. Both instruments didn't cross. We can see that this is the right hand, this is the left hand, this is the right hand. My scope go inside the wound between these two instruments. Okay, we can see that this is our wound. The 5mm scope is from the left side, and my both hand is on the right side of the scope. I didn't cross these two instruments, and I didn't cross my hand. The right hand is on the right side, the left hand is on the left side. We will get close to this area. Okay, we can see that this is the right hand dolphin. This is the left hand grasper. The 5mm scope go into the wound on the left side, and it is beneath the left hand grasper. So inside the abdomen, this scope is between two instruments. And my right hand is on the right side. My left hand is on the left side. This makes a triangulation more easy. We always know that the triangulation is the limitation of the SILC surgery. So from this procedure, we didn't cross the two hands between on the both sides of the scope. Sometimes you may think that the procedure make more difficult because the right hand, if the right hand will manage the left side area, you may transduce the scope to the right side of the dolphin. Okay, this is the same as the easy gallbladder. Sometimes the incision is too small. When you will fire the hemocrypt, the instrument you cannot introduce the hemocrypt into the abdomen. So I will use the other endograph to hold the gallbladder neck to the lateral side. And then now I didn't use my left hand grasper. There is just one instrument in the abdomen at the present time. Through the endograph traction, you can see that the color triangle is very clear. And I use the one instrument in the abdomen at the present time. Because the incision is too small, if you will enlarge the incision, you will remove the wound protector. It makes difficult. Okay, this is the cyst duct. Now this is the cyst artery. We also use one instrument in the abdomen. The easy gallbladder is more familiar to us. However, when you face the distended gallbladder, you cannot hold the gallbladder because it's very distended. I will use this puncture needle from the right upper abdomen to decompress the gallbladder first. Because if you use the 5 mm suction irrigation to decompress the gallbladder, there will be a big hole on the gallbladder, and the bile will spill during the operation. So I use this around 18 gauge puncture needle to decompress the gallbladder, and we can see that after decompression of the gallbladder, the bile will not spill from this small wound. Okay, we can see that this is a small wound, a small hole on the gallbladder. The bile will not spill out from the gallbladder. Okay, this is our patient's wound. This is the pre-operation. Among the 130 cases, there is only one case we insert the drainage tube. Because this is a SILC surgery, we didn't want to make another incision from the right side of the abdomen. So I insert the drainage tube from the bottom of the umbilicus. So after remove the drainage tube, we will make this incision patient to patient. Or we always make an incision from the skin fold. There is a skin fold here, so we make an incision lead at this area. So after this is about 1 month. 1 month operation, this incision will hide in the skin fold. Sometimes the patient is more fat, and we can make an incision from at the cranial side of the umbilicus. So after operation, the patient and even the patient cannot see her wound herself. Okay, this area on the cranial side after operation. 1 month also, this picture is also 1 month later. We cannot see the wound. Okay, nowadays around two years and a half, we make 100 and we can see my initial data to you. The conversion rate is 3 cases. Around 130 cases, we have 3 conversion cases. This 3 conversion cases is to the conventional laparoscopic, not the open surgery. Okay, we can see the mean operation time is around 70 minutes. The blood loss is around 20 millimeter. And I had 2 cases for postoperative bioleakage. These 2 cases, after I reviewed the video, I think the procedure is very normal. So these 2 cases, we have percutaneous drainage to decompress the viloma, and no ERBD. And around 2 to 3 weeks, this complication is subside. Then we compare the non-cholecystitis case and the acute cholecystitis case, and we can see the differences is the acute cholecystitis had more bile spillage during operation, more operation time, and it increased around 20 minutes. And the blood loss is more than the non-acute cholecystitis case. Okay, this is my initial data of the single incision laparoscopic cholecystectomy. This is our teammates from KMTTH OR. Okay. Thanks for your attention.
Any question from the audience? Excuse me, Dr. Su, I have 2 questions about your data. Now, you compare the conventional laparoscopic cholecystectomy versus the SILC group. Any benefit from the SILC? And
I didn't make the data between the laparoscopic conventional and the SILC. Further, I will do some study to these 2 groups.
If just for osmosis,
yeah,
you insist the SILC is better than the traditional laparoscopic cholecystectomy?
In some cases, I didn't make all the procedure as the SILC surgery because the SILC surgery will make more cost. So I always let the patient to choose the SILC surgery or mini laparoscopic cholecystectomy. I made the conventional laparoscopic cholecystectomy as the 2 3mm trocar and 1 11 trocar. 11mm trocar. So I didn't insist the SILC surgery.
And the second question about the bile leak. You have 2 cases of bile leakage.
Yeah.
Do you know what the bile comes from?
I didn't know.
City duct or from the liver bed or the previous gallbladder rupture related bile spillage?
Because these 2 cases, I didn't make the ERCP, so I didn't know these 2 cases. The bile is from the city duct stump or the liver bed. I don't know. So after percutaneous drainage, the complications subside. So I didn't know.
Professor, sir.
Thank you, your excellent talk. From your presentation, you did show when you perform the single pole laparoscopic cholecystectomy, you needed to cross over to keep the triangular shape of your instrument and the scope. But I know in your hospital you perform many low-bar single pole cholecystectomy. Can you compare these 2 kinds of single pole operation? Because in low-bar single pole, low bar can the design a low bar single pole. You needed to cross over the instrument during the low bar single pole. So how do you feel low bar single pole or laptop single pole corresponding in your experience?
Because I didn't practice robotic surgery before, so because the robotic surgery is expensive than this large port, so we published a comparison paper about the SILC and the robotic single-site surgery. There are no significant difference between these two groups, just the pain score. So because I didn't practice the robotic surgery, so I cannot answer the question about these two groups.
I have one question if you need. For the one instrument during the operation, for example, you need suction irrigation during the operation. So is it easy to introduce this instrument from this single port?
Suction tube.
Yes.
Suction.
Yes.
Because I have only one assistant. So when I use the suction irrigation system, I will remove the dolphin grasp and then use the suction tube. If you use the conventional suction irrigation tube, the distance is too long. So I purchased one longer suction irrigation tip. So I feel so easy for the suction of the body environment.
Okay. So you can introduce four instruments at the same time.
No, I always the three instruments.
Thank you.
Thanks, Dr. Su.